Thank you very much for the invitation, with a special thanks to the scientific committee and Nicole. So I thought I was going to go a bit more specific with examples of digital tools that we have developed in our group, but also go into how we collect data that then can be used for big data analysis and machine learning. So going a bit into the field. Our background of our work is actually quite simple. So there are too many children each year that still die from infections around the world, with the highest burden being in low and middle income countries. And then we also have not a novel, but an emerging threat, which has been antibiotic overuse in these children. So this is a recent estimate done based on health facility surveys in low and middle income countries by a group at Swiss Debate, where they estimated that 68% of sick children that come in for consultations get an antibiotic in the end. So this would be equivalent to your general pediatrician here in Switzerland, which accounts to about 24.5 episodes of receiving an antibiotic in the first 5 years of a child's life. Now, that is alarming, and I think has to be double-checked with other data that will be collected, but it certainly reflects of what we see in the field. So this is a booklet, a child health booklet that I took a picture of in Tanzania. In blue, you see the episodes where the child had a fever, and in red, you see the episodes where the child received an antibiotic, and that's an 18-month-old child, so if you count up, I think you kind of get to the 25 episodes of antibiotic exposure by age of 5. This is just a small cohort of 500 children from a study that we did in Dar es Salaam in Tanzania. And where we also found that 95% of children who come in with a fever get an antibiotic. And what's also true that the antibiotic prescription is also often inappropriate. So as you can see, I highlighted the diagnoses for which amoxicillin actually would be the appropriate treatments, and all the other diagnoses don't have an indication for amoxicillin treatment. What we also found that the dosing is wrong often. So alarmingly for people like infectious disease specialists like Nicole is when you give too little of an antibiotic. So about 30% got a dose within range, and actually 70% of those children got a dose that was too low by internationally accepted standards in terms of range. What we also know is that the large burden of antibiotic prescription happens at the primary care level. So most children, or patients in general, and children are seen in outpatient settings, and that's where the largest burden, estimates up to 74% of the antibiotic prescription happen. So that is why we work in primary healthcare settings and low and middle income settings. And we we've been working on developing digital health interventions for healthcare providers. So obviously there's a sprout of digital interventions that are coming out. My colleagues in low and middle income countries call them gadgets, which I think is a nice name for them. And really what we focus on are healthcare providers. And the type of healthcare provider that we work with are people that usually don't have medical training in the sense of a physician. So they might have 1 to 2 years of a medical training. They're often called clinical officers or assistant medical officers in those countries. So really what they're looking at is not a sophisticated differential diagnostic generator with probabilities of weighing each differential diagnosis in an intellectual manner. What they're looking for is really practical advice on how do I assess the child, what type of test should I be ordering, and what do I do with the results. And the tools that we developed, they have different abbreviations. I don't think we've landed on one across the different groups that work. We call them electronic decision support algorithms or decision support systems. So the abbreviation that is being used is ECDSA or ECDSS. And the reason why we've been focusing on these support tools is that we really believe that diagnostics go hand in hand with treatment decisions. what health workers are faced with in those settings are often outdated practice guidelines, unavailability of diagnostic tests, and a lack of supervision, which then leads often to inappropriate treatment decisions. So you can't untangle treatment decisions from diagnostic support. Diagnostics are really important. Our starting point from a strategy and content perspective is the IMCI strategy by WHO, which was developed about 30 years ago. What was the heart of IMCI is really the integrated management. So not to look at pneumonia at one silo, look at HIV in another silo, look at TB in another silo, diarrhea in another silo, but to really combine one into a comprehensive healthcare strategy. And in that, we believe that our tools, which I'll show, are really supporting this strategy. And then from a content perspective, it's been the starting point for developing our tools, which again also serve as, in a way, data collection tools and how we collect data in the field. So it follows a very simple procedure of assessment, symptoms and clinical signs, classification and treatment. And the tools that we develop in the flow, like in terms of user interface, how the clinician needs to use them, obviously needs to follow the logic and the logic of a medical consultation. So we'll always follow that logic. So in practice, a typical output of the tools would be what symptoms does the child have for some basic clinical signs, based on those signs, what type of test should be ordered, and then how to interpret them in an integrated manner. Let's look a little bit more at IMCI to understand what we've done in terms of content development and why we had to extend content. So if you go into the depth of IMCI, it actually doesn't give a ton of guidance in a lot of sections. So let's look at the fever section. So it says, look or feel for stiff neck, okay. Might be a challenge in young children. Look for runny nose, okay. And then look for any bacterial cause of fever. Well, that's a bit more complicated. That's I don't know how to do that. And then look for signs of measles. And then it has these asterisks. There's a lot of famous asterisks. So it's look for local tenderness. Okay, where should I look for that? Oral sores, but which, could be a sign of measles, but it's really more associated with viral infections. Refusal to use a limb. Hot tender swelling, red tender skin boils, low abdominal pain, or pain on passing urine in older children. So I think for the clinicians in the room, it's very clear this is quite vague, and you don't really know, especially if you don't have, I wouldn't know what to do with this, really. And if you don't have a lot of training, it's very hard to follow those guidelines. So if you operationalize these guidelines into step-to-step algorithms, you have to take a lot of decisions on what that actually means and how the content should look like. And then when you go on to the treatment section, malaria test negative, don't give an antimalarial, that's very clear. If other cause of fever present, which is not bacterial, don't give an antibiotic. And then if there's a bacterial infection, give appropriate antibiotic treatment. So if you can see, it's a guideline. It's a lot of interpretation, and it doesn't give step-to-step guidance. So what we've done in the past years to extend on that content and the tools that we've developed to include disease etiology as also a marker for pretest probability of a disease to occur. We've developed clinical and lab decision trees, and we also added on host biomarkers, and I'll show a little bit of an example why that might be important in some branches, and integrated that into one digital tool. What we typically do when we start developing these ECDS contents is to decide on the scope first. So what do we want to cover? For the first version of our tool, which is called Epoc, we decided to cover the IMCI range 2 months to 5 years with children with fever. Then decide based on disease prevalence data, which diagnostic classifications to include, so which ones are most important. We then identify areas where there's a lot of evidence, a lot of guidance, and as you can see in the guidelines, there might be areas where additional guidance is needed, and where which are amenable to doing scoping reviews in the literature. We perform scoping reviews in the literature, then refine those guidelines in terms of the content, And then what's really important, we always have an external review, which is usually country-based, to make sure that what we develop stays relevant in country and is appropriate in terms of policy. That being said, we obviously acknowledge that the evidence base around pediatric infections isn't great. So there's a lot of analytical epidemiological data. So what I mean by analytical data is things like, if you have an infiltrate on chest X-ray, what is your CRP value? So cross-sectional data and cohort studies. There's very little clinical outcome-based data. So a lot of what we have, we can't really base on strong evidence. And when we do our reviews, we obviously think also about the fact, when we then go and test those and collect data, how can we actually then feed back into the global evidence base around infectious diseases in pediatrics. So I'm going to walk you to one example that we've done to give it a bit more of a concrete feeling. The Imci cough branch, as it stands now, has one step, which is a clinical screening step. Includes demographics, so age, medical history, so do you have a cough and a fever, and then clinical sign, which is basically two. Do you have chest indrawing, which might be a sign for respiratory distress, or tachypnea, so fast breathing. And then based on that, the children are classified into severe disease requiring hospital-based treatment and antibiotics, clinical pneumonia, or fast-breathing pneumonia, as it's called in Imci, you give antibiotics, or you have a presumed self-limiting viral infection, and you don't get antibiotics. So that's what the Imci says at the moment. We've extended for the Epoc that I will show the tool, we've extended that a little bit. So very importantly, we kept an initial screening, a clinical screening step, using demographics, some refined clinical science, so what we did with the respiratory rate, because we know that the respiratory rate rises when a child has a fever. It's sort of like a ventilator where they're breathing off steam. We actually corrected that based on percentiles that had been published for age and for temperature, which can be done with a digital tool, but it's obviously not something, two-page lookup table. It's not something that you can use on paper and practice. And then we kept an initial clinical screening step. We introduced the pulse oximetry, which is a tool to identify the need for oxygen treatment at the hospital in children with severe infection. So that's one tool that was added. And then added a second step to a more specific step to test for bacterial pneumonia. The reason that we kept the clinical rule or rule-in, rule-out step, depending on where you see it, is that for a diagnostic test to be useful, you need a relevant pretest probability for that disease. So you can't, as it's been done, or proposed in some parts, you can't just put out a biomarker test, especially in peripheral care settings for screening. So you still need that initial clinical screening step to be able to use the biomarker. What we use the CRP in that case to decide then, does the child need an antibiotic or does the child not need an antibiotic? And all of that can be supported in the background, so the input and output screens for the clinician stay quite simple, and it's because the background calculations are supported by the electronic tool. So I'm just going to walk you through the concrete example of what that looked like. You see Valerie, because this was done for the Swiss television, so she's prominent. Mom comes in. Dr. Samaka is a health worker that's using the Epoc tool. So the first step, she takes the oxygen saturation. She enters some basic vital signs. A weight, which is important also for antibiotic dosage calculation. This is the clinical screening step that I talked about, and asking about main symptoms, main clinical signs. Then based on that, the algorithm will propose the appropriate laboratory tests to perform. So everybody who has a fever in Tanzania will get a malaria test. And this child had a sufficient pretest probability for pneumonia, so it proposes a CRP test. There are lateral flow tests that we use, so they can be used in peripheral care settings. And the red box is a hemoglobin test. So one of the comorbidities that's quite prevalent due to different reasons in Africa is anemia, and it's actually a risk factor for developing severe disease. So we also included that as a severity marker in the algorithm. So this child is not anemic and had a low CRP. So in the end, the output will be a viral, what we call a viral pneumonia. And then importantly, the next step is counseling, because, you know, as you've also experienced, it's never nice to be like, oh, you have nothing and go home. What's important if you don't prescribe antibiotics is to do counseling, what that is and what that means and why the child doesn't need a treatment. And there you see weight-based paracetamol dosing. So when we had developed the Epoc tool, we really thought a lot about how to validate that. And we decided to follow the steps that were sort of put out by the WHO digital health group, but also kind of the steps that follow around classical diagnostic tests. That being said, there aren't any clear guidance on how to evaluate electronic algorithms or electronic tools in these settings. So the first study that we performed, which I'll present the results, go along an efficacy study. So does this work in controlled settings as a first step? So the Epoc efficacy study, in parentheses because it's not a drug, obviously, we performed was an individually randomized study among children with fever 2 to 59 months in 9 outpatient centers in Dar es Salaam, randomized to Epoc, and then an electronic version of the Imci tool. And we followed them up at day 3, day 7, or day 30 for the primary outcome, which was we call clinical failure. So it was a combination of either developing severe symptoms in the interim, requiring hospitalization, or having significant persistence of symptoms at day 7. We also looked at secondary hospitalizations and death. For the cough branch, we had a lot of children have cough, so out of the 3,200 children that were randomized, we had around 850 in both groups with cough. Few were last to follow up, and we did a subgroup analysis for that branch that I just showed. So what we were able to see in terms of antibiotic prescription at day 0 is that it reduced dramatically. So if you apply MCI strictly with the clinical screening step, these about 40% of children who come in with cough got an antibiotic, and using the CRP test at a pretty high cutoff of 80, we were able to reduce that to 2%. Again, controlled settings, not routine implementation. It's something that Valerie will talk about in her talk. And then the clinical outcome was similar, and maybe we're not quite sure was not powered. The study wasn't powered to the subgroup analysis even better at day 7. And it kind of just to show how the diagnostic classifications presented. So this is IMCI, so 60%, so those are the ones who had the low respiratory rate, don't get an antibiotic. 36% are the ones with a high respiratory rate, so fast breathing, based on IMCI, who got a presumed antibiotic treatment for clinical pneumonia. With Epoc, we used a more sensitive screening step initially, so more children were initially ruled in for pneumonia, and then a lot of them were kicked out again based on the low CRP result, and we ended up with 2% of antibiotics. The green ones, you see, those are overlap diagnoses. Diagnosis where children had 2 reasons to get an antibiotic based on the integrated assessment of the algorithm. Some next steps, and stay tuned for the next talk. Valerie will go a little bit into, what do you do when you go into implementation and looking at effectiveness in routine settings. I just wanted to point out some ideas that we're looking at in terms of the content, what are the next steps in the content. So something that we've submitted to funding is to add more granularity to the cough branch. The cough branch is a convolution of a lot of things. So you obviously have bacterial pneumonia, which I think I was able to show actually represents the smallest percentage. You have a lot of viral diseases. And we've known that as clinicians for a long time, but now there's been more epidemiological evidence that bronchiolitis kills a lot of patients in low and middle income countries. There's also more exposure with climate change to air pollutants, so asthma is a big topic. Nicole has TB, not to forget, there's things like sickle cell disease. So this cough branch is a convoluted thing of many diagnoses. So one promising tool that we would like to evaluate is the use of what's called a digital smart stethoscope. So these are stethoscopes that are digital and record sounds. And with that, you can, it's sort of, some people call it the Shazam of the doctor's stethoscope. So what we typically use for assessment as clinicians to look at severity, but also at specific patterns that can point to these different classifications could be achieved with a digital stethoscope. There's also been a lot of interest in ultrasound and using point-of-care ultrasound in low and middle income countries as an alternative way to the CRP testing or to the test to diagnose pneumonia. There are some tools that have been developed that are very amenable to being implemented in these settings. And the advantage is that it's a test that can be used for many different things in a health worker that takes care of pregnant women and children and older people at the same time. And then we've also, out of the recognition for the current effectiveness study, actually extended the content quite a bit. To include neonates, because that's a really high-risk group, the children under 2 months. So we've now developed in collaboration with a neonatal epidemiologist at Swiss TBH, Gillian, an algorithm for the young infants, and would also like to extend that a little bit more into the hospital setting. And this was done by Rainer Tan and Nina Wesiper. We've extended the spectrum of the current Epoc algorithm to basically every child coming into the health facility. That's very important for implementation because you don't want to have a tool that you can use in child A but not in child B. And we've also paid more attention to chronic risk factors because we saw from the Epoc data that they're very, very important in determining who's going to die from an infection. So one is sickle cell disease, which has been completely neglected in the primary care world, and then other risk factors such as severe acute malnutrition. We've also developed, in collaboration with Josephine van der Maat, a doctor at Rotterdam University, and Annie Hartley, who's in the room, a triage algorithm, a tree, because this is not happening. It's very basic. We do this in high-income settings all the time, where you prioritize kids that arrive at the health facility in terms of priority, but it's not implemented, in these remote settings. So we developed a simple tool based on existing hospital-based triage tools in low and middle income settings, which was vetted by a Delphi survey with experts in Tanzania. And then an idea that, this is Annie's slide. I don't do slides like this. I don't think Annie has a great mind, which I don't have. The idea was to actually go a step further and maybe do some, to put the triage in hands of the patients who are waiting. So this is an idea which has been submitted to funding. The idea being, people wait in the waiting room very long, much longer than here, and they can pre-enter certain symptoms and diagnosis, and we can compare that with the outcome that is given by the provider assessment and see if one actually does then task shiftings. And then the idea being that you can actually move triage even further away, to outside of the health facility. So with that, I'd like to thank you for inviting me to talk. I have a lot of collaborators here in Switzerland, Europe, and Tanzania, and below our main funders for the work that's been done. Thank you very much for your attention.